Good day, my dear student. This is the last rapid revision class in pathology, and I shall be confining to hematology. Hence the term rip through hematology. In today's class, we shall be dealing with transfusion and miscellaneous topics. Please be careful with these topics because these are oft asked questions which we perform very badly. So it would be essential that you answer to the point and understand the question well. When it comes to blood transfusion, you are supposed to know the procedures, the precautions, what screening test would you do, what are the indications and the complications. A basic thing. For example, I won't be surprised if a blood bag is with the examiner and he asks some viva question out of it. Anyway, let us see what best we can do with this. So this is a blood bag which you people should identify. Normally, the blood group is written on this. Also, you find that there will be a number which is peculiar to the blood bank. And from that, the register could be traced from which all the details about the donor can be obtained. Also, the date of collection will be there. Normally, the blood bag is supposed to be preserved for a period of 30 to 35 days, not beyond that. So, you find that these things will be mentioned and should be taken care of. This is another bag in which I am finding a plasma that has been separated. So, you find these are all collapsible bags. Earlier, the blood used to be collected in bottles. But now, with air embolism and also the sepsis becoming rampant, it has been changed to blood bags, which are sealed, and after that, they are most sterile to handle. One unit of blood can save 3 lives. And usually the unit in the blood bank is 1 pint. And 1 pint means this is the measurement, 473.18 ml. So you find that once it is being separated from the blood, you can have a concentrated RBC, a plasma that is rich in platelets, or a platelet poor plasma. Generally, anticoagulants. This can be asked as a question itself. It is not very difficult, and I would like you people to kindly memorize this particular page. This can also come as an MCQ. For example, why do you use a double oxalate mixture? One will be causing contraction, the other will be causing expansion. In order to balance, there will be a double oxalate mixture. Mixture of ammonium oxalate and potassium oxalate. EDTA, this is the most common anticoagulant that is used in hematology. It is the EDTA powder, ethylene diamine tetraacetic acid. Trisodium citrate, 3.8% trisodium citrate is the answer that you people should give in ESR. Also, you find that 1% trisodium citrate, sodium citrate can also be used. Acid citrate dextrose is the anticoagulant in the blood bank. And of course, you have got heparin for therapeutic purposes and so warfarin. These are costly and you should know. For pharmacology, the answer is different. For pathology, the answer is different. And please look at this. This is the blood bag we have been talking about. And it will carry the label with all the details. The number, which will lead to the details of the donor, the date of collection, what group it is, and so on. Also, you find that there will be a provision for the blood to be passed on to the next bags. After a very gentle centrifugation, when the RBC settle down to the bottom, there is a mild compression so that the supernatant plasma moves on to the next bag. And by this, you find that there can be the RBC concentrate, which can be used for a patient with severe anemia. There can be the plasma for the patient with dehydration. There can be the platelets for a patient who has got bleeding disorders. So these things can be borne in mind. The same thing is mentioned here. I would like you people to kindly memorize this. So RBC, red blood cells, fresh frozen plasma, concentrate of plasma, and cryoprecipitate. And what are the uses of it? Cryoprecipitate, for example, for fibrinogen deficiency. And the storage period is also mentioned. Though it is mentioned as 42 days, 35 days will be ideal, beyond which we are not supposed to. And this is the period for the other components. So kindly go through this particular one. I would like you people to have a very clear idea, because blood grouping is a definite practical for you people. And also the various questions that I'm going to discuss will be asked in your theory as well as in the Viva. So this is another one. I'm taking a small break. It is not the hours that you put in your work that count, but it is the work that you put in your hours. San Heavy. I would like you people to kindly recollect, read and revise what we have covered so far in hematology alone. So when it is bleeding disorders, in today's class, I shall be dealing with these components. And these can be, we have already covered this one, they can be essay questions for us. These are usual short notes. And very rarely you may get questions like this. So I divided into the must know, nice to know, and the relatively rare questions. So also for anemia, definitely a must know, because these are all part of the essay or essay questions. And these are all repeatedly asked short notes. And this is again a nice to know, or they can form part of an MCQ and so on. So these things, be very careful whether you know it. Go to the book and go back to the class on R.A.T.S. And this is the leukemias and the WBCs. The leukemias and the leukemoid reaction I have covered. Apart from that, these can be asked. And these are again nice to know. For example, when you are having a differential count, they can very easily ask you anything about eosinophilia, lymphocytosis, neutrophilia, etc., which we are supposed to answer. And this is what we are dealing with now. The transfusion, these are all the major essay questions, and this can be the short note. These are again repeatedly asked short notes, which we should be prepared. The transfusion reactions. Normally, when such a question is being asked, the students fumble with it. I would like you people to kindly divide your answer into immune reactions, non-immune complications, and what are all the various things that come under it. For example, there can be hemolysis, allergy, anaphylaxis, and sometimes it can be delayed also. And what is the cause for it? What is the investigation that you can? And how do you manage? For example, you will have to discontinue the transfusion, or you will have to give the antihistamine and so on. Coming to the complications again, you find that one such complication, I am finding a lot of bubbles over here, can be an air embolism. I keep the blood bag open, so I find that there can be air entry into it that can lead to an air embolism. That is why promptly they should be clipped and removed once it is over. Also, too much of transfusion can lead to a cardiac overload. These are all things that you people should have in mind. So look at this non-immune reactions in blood transfusion. These are all the reactions. This particular list I would like you people to kindly memorize because you won't be having time when it is asked in the viva or in the practicals. So the febrile reaction, circulatory overload, so on and so forth. Preserve this one. It is worth its weight in gold. And what is the cause for it? You may or may not know. But then this is again a good for us. So you find that what are all the other investigations that can be done. And how do you manage? Mainly simple common sense. Stop the transfusion. Give any supportive treatment, antihistamine, so on. So this is the cardiac overload that I've been talking about. Supposing a friend of yours is admitted and you want to give lots of blood, obviously the patient will go in for cardiac. So the immune complications, again, it is here in the text form. I would like you people to kindly memorize. So what are the immune complications? What are the non-immune complications? I have not yet touched the infections. Look at this one, the non-immune reactions. So these are all the things that can happen. Also, the infections are over here separately. I would like you people to kindly memorize the infections. What are the common infections spread by blood? Very repeatedly asked questions and always have a list with you people. Hepatitis is very common. Okay, HIV is there and any of the viral infections. Parasites, particularly malaria. And this is the most common, gram-positive or negative septicemia. Bacteria can be there. So this is the list over here, which you people should. Don't answer very rare questions, answers like Chagas disease, though I had given it. So the most common will be the bacterial infections. Apart from that, you can have viral such as hepatitis or HIV. So this is another one, the erythroblastosis fetalis. Again, a repeatedly asked question in our university and any other university, MGR University and all over India it has been asked. So I find that this is the way you people will have to explain this. So there is the mother who is supposed to be Rh negative and the child is Rh positive. So what happens is you find that the positive antigen enters the maternal circulation and there is a production of the antibodies. So once there is a delivery, you find that there will be a tear in the placenta and there will be the entry of the fetal antigens into the mother's blood. So there will be the antibodies produced. But by the time the fetus is delivered, so the fetus is safe. But during the second delivery or after an abortion, you find that the mother will be loaded with the antibodies, Rh antibodies. So these will cross and they will be leading to hemolysis within the child. There is a severe jaundice that happens, which is called as erythroblastosis fetalis or a hemolytic disease of the newborn. The answer is there in itself. There is a lysis of the newborn fetus, fetal blood. And how do you prevent it? There is supposed to be a sensitization that has to be done. You give the anti-D antibody to the Rh negative. And also, what are the various investigations that can be done? This is the battery of investigation. Very simple, just memorize. You'll have to do the blood grouping, you'll have to do the Rh typing, you'll have to test for the D antigen and identify the level of the anti-D antibody, etc. And same set of investigations you will do in the fetus. Obviously, there will be the Coombs test which will have to be done. This is another question by itself. So, you people have got two answers in one. I would like you people to kindly memorize, draw the earlier diagram, and that will be a success. And this is the text. You people can trace it in your own textbook and read it out. So this is the Coombs test. Again, this particular diagram is important. There are two types of it, the direct Coombs and the indirect Coombs. In one, you find there is only the antigen, but in the second one, you find that there are antibodies, and these antibodies get attached and then they act as antigen themselves. So there will be the antibodies against them that are there, which will lead to the clumping of the blood. So this is the direct wounds, and then there is an indirect wounds. In one, there won't be any antibody in the serum. In the second one, there will be antibody in the serum. You people can just read it up. It is a repeatedly asked question. I think this diagram will be very useful for you. And what are the indications of the Coombs test? I don't think I can give you a better tip. So in all these conditions, particularly the hemolytic disease of the newborn, any of the antibodies, warm antibody or the cold antibody, it can be done. And also for the screening, it can be done. And other hemolytic anemias also, it can be done. Now, these two tables are for you people to read. There is no text, just read this table alone. Bone marrow transplantation. There can be an indication for bone marrow transplantation. When will you do a bone marrow transplantation? Remember R. There is a severe refractory anemia, severe aplastic anemia, relapse of any of the disease that is being treated, and also a refractory leukemia, etc., not responding to any treatment. So there can be a relapse, or there can be a kind of lack of response. For this, you will be doing it. And these are the major conditions you people can just go through. The complications, after all, even the transfusion is supposed to be something like a tissue transplantation. So there can be a graft rejection, graft versus host disease, etc. Infections can be there. So this is another call. Just these two alone. There is no text for you people. In case you are asked, this can save us. This is our darling, the age-old friend, the erythrocyte sedimentation rate. To my knowledge, in each and every college and university, this question has been asked at least 12 times in the recent past. And students have written it very badly. So erythrocyte sedimentation rate. So this is one method. Before I go to the other one, in this one, we are not sucking the blood. It is a disposable tube, and once I keep it in, this will be containing the blood, and once I push it in, it goes up by capillary action. And after that, it is being sealed, and the RBCs are allowed to sediment. This is one. The length of this tube will be about 200 millimeters, whereas normally it can be, this is called the Westergren's tube. This will be kept for the examination viva as a spotter or for identification as a spotter. So the length in this case is again 200 millimeters of graduation. Then there will be about 10 millimeters. So the total length is about 300 millimeters. And what is going to be the inner diameter? It is mentioned over here, 2.5 millimeters. What is the graduation? 200. What is non-graduated? 100. Totally it is 300. What is the anticoagulant that is used? Trisodium citrate that is being used. So this is one, and you people will have to mention all the causes, etc., which you will be seeing. This is another tube called the Winthrop's tube. The Winthrop's tube is for the Winthrop's method of the ESR. It is 11 centimeters, graduated up to 10 centimeters. It is open only at one end. The other end is closed. So I'll have to use a long pipette called the Pasteur pipette for filling the blood. After which it is left as it is, and the reading is being taken. The inner diameter, etc., is given. Also, please note that if it is going to be from 0 to 100 millimeters, it is for the sedimentation. Whereas if it is from 100 to 0, it is for packed cell volume. So this can be used as a hematocrit tube or a PCV tube also. The same tube is used for both the purposes. But for PCV, we will have to centrifuge it. After centrifugation, the RBC will sediment, and I will have to see. I'll show that again. So this is the stages of the ESR, the roll formation, sedimentation, packing. You people will have to write. And what are the conditions where it is Your Hutchison clinical medicine mentions that the ESR can be raised in any condition ranging from cough to coma. But more important will be, say, conditions like myocardial infarction. Any of the inflammations, it will be raised. Also in tuberculosis, it is of prognostic value, whether the patient is responding to treatment or not. But more important, a favorite MCQ of mine is in multiple myeloma, it can be as much as 100 millimeters per hour. So the range is all given over here. Kindly go through this. What are the ranges? What is the anticoagulant? And what are the other conditions that will be affecting the ESR, such as the verticality of the tube, the room temperature, etc. You people should mention. So significance of the hematocrit is the PCV. So in this one, once there is a centrifugation, there will be the RBC, then there is a Buffy code, there will be a plasma. So this is over here. From the RBC, I can diagnose all these conditions. Polycythemia, anemia, and in severe dehydration, again it is raised. Buffy code, mainly for the LE cell or increase in the leukocytosis. If it is very thick, then we will have to suspect a leukemia. Plasma, of course, if it is going to be very pink in color, then there can be hemolysis. Yellow in color, it is suggestive of jaundice. And if it is going to be whitish, probably cholesterol is increased. So this particular column also you people will have to by heart. And this is another instrument called the zetafuge or the microcentrifuge, in which I'll be able to assess the ESR, etc. So this is again the thing. Most reliable one is this. The PCV, what are all the types that are over here? The Winthrop's method, microhematocrit, etc. And what are the advantages? What are the various values I have mentioned? This kind of a diagram you people can draw in your Excel. This is again an age-old friend of ours. Hemoglobin estimation will definitely be there, such as blood grouping. So in this one, you'll have to know the different methods of hemoglobin, etc. I'm not going to go into the details, but I insist that you should go to my class on hemoglobin estimation, wherein I have given all the variations, the causes for error, etc. And what can be the other uses of this. So kindly go to that one. I would like you people to kindly read up everything about hemoglobin estimation and blood grouping, ESR and PCV. So this is what is called as a sysmix. It is an automatic differential counter. The moment I keep a small volume of blood, the adequate volume is being sucked in, and after that it is being analyzed by the machine. It is called the sysmix, and you get a 5-part differential count in this one, depending on the size of the cell, etc. And that can be projected onto a monitor. If necessary, we can take a printout of it. Very rapidly, we'll be able to get all the values and the machine analyzes everything. So please remember either the Sysmex or the Bettman Coulter. These are two companies which are common for the automatic cell counters. This you will have to mention, because if you answer well in the exam, they will ask you, is there any other method? The hemoglobin is very defective. Can there be a better method of doing it? So on. And the anticoagulant, you people will have to mention. Drapkin solution is supposed to be the ideal method for hemoglobin estimation. Go back to my class and you will be able to read it completely. This again can be a question. This is called the LE cell. So in the case of systemic lupus erythematosus, that is why it is called LE. There is a homogenization of the cell, and that is being ingested by another cell, and this is called the LE body. The whole thing is called the LE cell. This will be picking up from the Buffy code to diagnose conditions such as rheumatoid arthritis and systemic lupus erythematosus. There can be a similar one in which there is no homogenization and the nucleus is well preserved. This is called a TART cell because it was identified in a patient called TART. So this is a differential diagnosis. So LE cell can be a question for you people, and if you do mention in the answer on SLE, you get a point for it. So that completes my entire revision on hematology. I hope this has been useful for you people. I would like you people to kindly follow the same thing. See my descriptions, go back to your text, and also go back to R.A.T.S. That will be the major one. In each of the questions, I have mentioned what is the source of answer you will have to rely on, how to develop your answer. You should not get less than 80% mark in hematology. I wish you all the best.